it's so important now as we approach early relapse, in particular in myeloma, that we try to do so very methodically. And as I've often said, we don't have a simple algorithm anymore. We don't just say, I always give this first line, I always give this second line, et cetera. Well, we have to make choices. And thankfully, we have choices to make, right? Especially in the US, we're blessed by the number of options that are available to us. But we have now a plethora of phase 3 trials that have historically compared triplets versus doublets. So we've proven pretty much that triplets are better than doublets. It's better to give, daratumumab, carfilzomib-dex versus just carfilzomib-dex. It's better to give isatuximab, pom-dex than just pom-dex. So those have been proven. What we sought to do in this study, again, not in a prospective phase 3 trial, but an analysis of pooled data to say, how do we compare across these phase 3 trials, which of course comes with all the caveats of not being able to compare across trial. But it really depends on multiple factors. But what we tried to demonstrate is that when we use, carfilzomib containing regimens, there does seem to be a prolonged progression-free survival. And it may be that we can give these drugs now a more indefinite way. In carfilzomib, we used to stop at a certain number of cycles. Now we give it more indefinitely. And it's not to say that we can't or should not use pomalidomide-based regimens. But in a world where most patients are progressing on lenalidomide, we can indeed overcome that resistance with pomalidomide, but it may be preferable to change that mechanism of action. And sure enough, when we look at all of these phase 3 trials together, it's not really surprising that we saw with Candor, which was daratumumab plus carfilzomib versus carfilzomib-dex, and with IKEMA, with isatuximab, carfilzomib-dex versus carfilzomib-dex, that those had independently themselves the longest progression-free survival. Indeed, with IKEMA, it was a 3-year progression-free survival, something we really hadn't seen in early relapse. So we just tried to capture that data in another angle and another way. I wouldn't say it's absolutely definitive, but I think it does reflect that right now, in many of our patients that have had a VRD-like regimen, with or without a transplant, and are progressing on lenalidomide maintenance, we want to use a CD38 antibody, typically daratumumab or isatuximab, and we try to decide what's the better partner. Is it carfilzomib? Is it pomalidomide? Is it selinexor even? And here it seemed to indicate that using a carfilzomib-based regimen may provide a longer PFS. As I mentioned, with all of the caveats that we have to individually tailor it to our patients. But I think it just adds to the reality that thankfully we have many choices for our patients.